A very good evening to all. This is the third day in the series of the new concept of INI-CET which we are following. We will be discussing one topic with the help of one MCQ and preferably few more MCQs which can be asked in the similar topic. And we try to have a complete review of that topic so that the entire topic is understood by everyone and nobody falters in exams whenever this question is getting repeated again and again. So the topic of today is an infant of diabetic mother. So infant of diabetic mother is a very important topic when it comes to pediatrics, more so because it is associated with hell lot of complications, and infant of diabetic mother is a nidus for having so many abnormalities and pathologies which can be seen and which can be troubling the neonatologist as well as the baby both in terms of the problems which can be seen in them. Not only there will be problems at the metabolic level, but also there will be problems at the level of major organs, and also there will be an element of what congenital malformations which you have to be aware of. So with this we start with today's topic of infant of diabetic mother. We just go through the first question and try to see how well we can understand the topic of infant of diabetic mother. So here we have an infant of diabetic mother who is weighing 3.8 kilos. Remember, 3.8 kilos from an Indian point of view, it seems to be a large for gestational age. But in what you call in absolute terms, if you want to call a baby who is newborn and is macrosomic, the birth weight should be more than 4 kilograms. So his birth weight is on the higher side. Now this baby is presenting with seizures after 16 hours of birth. Now the question is, what is the cause? Now if you look into the options, the option A is hypoglycemia, option B is hypocalcemia, option C is birth asphyxia, option D is intraventricular hemorrhage. Now if you look into the differential diagnosis of neonatal seizures, all four of them are associated with seizures. So here we need to identify the best possible match for this question. So the clues for this question would be that the baby is an infant of diabetic mother. He is macrosomic, and likely macrosomic, though the cutoff is not reaching that threshold, and he is having seizures, and that is at 16 hours of life. So the most common cause of seizure in an infant of diabetic mother is going to be hypoglycemia for all practical purposes. Though the infant of diabetic mother can be associated with hypocalcemia, there may be coexisting birth asphyxia or an intraventricular hemorrhage because of various reasons, but these four clues are going to provide that the differential diagnosis for this question would be hypoglycemia, because hypoglycemia has been found to be consistently associated with seizure. The onset of hypoglycemia can occur as early as 1 to 3 hours of life, and an RDR of around 45 milligrams per deciliter is soon achieved by around 16 hours when the patient starts developing seizures again. So the definition of neonatal hypoglycemia is very important. So what exactly is the definition of hypoglycemia? The definition of hypoglycemia involves a particular cutoff, and this particular cutoff is different for plasma glucose and different for blood glucose. So the blood glucose value of less than 40 milligram per deciliter or a plasma glucose level of less than 45 milligram per deciliter is considered to be definition of neonatal hypoglycemia. Always remember, though the patient satisfies the criteria for neonatal hypoglycemia, the patient the neonate may need not be necessarily symptomatic. That means we have two types of hypoglycemia. One is a symptomatic hypoglycemia where the neonate is having symptoms because of hypoglycemia. Two is a hypoglycemia which is relatively asymptomatic. So if you look into those neonates who are presenting with symptomatic hypoglycemia, there is hell lot of clinical manifestations of hypoglycemia which you can note in those babies. Right from jitteriness, which is a seizure mimic, irritability, hypotonia, lethargy, high-pitched cry, hypothermia, poor suck, tachypnea, cyanosis, apnea, seizures, and cardiac arrest. All can be the manifestations of hypoglycemia. Now, in general, if you talk about the etiologies of hypoglycemia, you need to have the common etiologies first, which includes nothing but prematurity. So, prematurity is one of the most common cause of hypoglycemia. This is followed by intrauterine growth retardations, small for gestational age, large for gestational age, perinatal asphyxia, hemolytic disease of newborn, neonatal sepsis, polycythemia, post-exchange transfusion, parenteral nutrition, and an infant of diabetic mother. From all these differential diagnoses, the point which is relevant to our question was an infant of diabetic mother with the setting of macrosomia, probably presenting at 16 hours of life with an episode of seizure. All these are pointing towards the hypoglycemia as a etiology. Hypoglycemia as a etiology. So the next question comes: how do I manage this patient with this baby with hypoglycemia? So the management of hypoglycemia depends upon whether the baby is symptomatic or asymptomatic. If the baby is having asymptomatic hypoglycemia, see how low is the blood glucose. Is it terribly low, less than 20 milligram per deciliter, or is it between 20 to 40 milligram per deciliter? Because the definition of hypoglycemia is a blood glucose of less than 40 milligram per deciliter. Now, if it is extremely low, then you need to have the baby started on glucose infusion. That is, dextrose infusion at the rate of 6 milligram per kg per minute is the solution for this asymptomatic hypoglycemia with a blood glucose level of less than 20 milligram per deciliter. You need to repeat the blood glucose after 60 minutes and titrate the glucose infusion rate. GIR stands for glucose infusion rate. If the blood glucose level keeps below the level of 40 milligram per deciliter, you will have to increase the glucose infusion rate from 6 to 8, 8 to 10, 10 to 12, depending upon the degree of hypoglycemia. If the baby is having asymptomatic hypoglycemia, every attempt should be made to give NG feeds or oral feeds in order to prevent conversion of a asymptomatic hypoglycemia to symptomatic hypoglycemia. Again, after giving the oral feeds, either to the NG tube or by Katori, what you are supposed to do is you have to repeat the blood glucose after 60 minutes of giving oral feeds. If the baby is showing less than 40 milligram per deciliter of blood glucose, then at that point of time you need to start the infusion of dextrose. However, if the blood sugar is more than 40 milligram per deciliter, then you will have to chart 2 hourly feeds and monitor the blood sugars every 6 hourly for a period of around 2 days. So this is the management protocol of patients with asymptomatic hypoglycemia. Now, at any point of time during the course of management of a patient with asymptomatic hypoglycemia, if the neonate develops symptoms, then you will have to shift to the symptomatic hypoglycemia protocol. Now, what is the symptomatic hypoglycemia protocol? So this symptomatic hypoglycemia protocol starts with direct giving a IV dextrose in the form of bolus at the dose of 2 ml per kg. For example, if you have a 3 kilogram baby or 3.8 kilogram baby, as in our case, so you need to use 2 into 4, that is 8 ml of 10% dextrose that should be given at this bolus, and this should be followed by an infusion which is given at the dose of 6 to 8 milligram per kg per minute. Again, repeat the blood glucose after 60 minutes. Now here the next step will be dependent on whether the blood glucose level is less than 50 or more than 50. If the blood glucose level is more than 50, then for 2 consecutive hours, then at this point of time you can just monitor sugars every 6 hourly and start feeds once 2 sugar values are above the 50 milligram per deciliter. Now when you do that, you start tapering the glucose infusion rate to 4 milligram per kg per minute and then gradually switch over to oral feeds. If the blood glucose level is less than 50 milligrams, now keep on increasing the glucose infusion rate at the increments of 2 milligram per kg per minute to a maximum value of 12 milligram per kg per minute, and after that you can monitor the sugars every 30 minutes and see whether the sugar is more than 50 or less than 50 and accordingly titrate it. Now, one more important thing we should remember is a peripheral cannula can get blocked if you use 12.5% dextrose or more. So that's the reason why whenever you are giving IV dextrose, it has to be 10%, and if at all you are using 12.5 or 25% dextrose, then it's preferable that you give it through a central vein. So, and everybody knows placement of a central IV cannula is going to be very difficult, especially in neonates. So you should be equipped with that. Exactly is happening in a diabetic mother. Why is this infant having so many problems? So this flow chart can summarize everything for you. So whenever there is a maternal diabetes, because of the hyperglycemia which is there in the maternal blood, there will be a compensatory hyperinsulinemic state in the fetus. So because of the response of the maternal increase in blood glucose level, there will be fetal hyperinsulinemia. And everybody knows insulin is an anabolic organ, anabolic hormone. So it results in anabolism. So there will be basal cell hyperplasia because of the insulin which is anabolic effect, which results in large for gestational age. Almost all parts of the body, all organs of the body enlarges, except few, which we'll be discussing as an MCQ in the subsequent class. And then you will have macrosomia. Whenever there is a macrosomia, there will be difficult labor because of the shoulder dystocia, and the child may have birth trauma, asphyxia, brachial plexus injury, and a fractured clavicle also. At the same time, in response to the insulin itself, there may be cardiac hypertrophy, which can manifest as asymmetrical septal hypertrophy of the interventricular septum, which is again one of the most common congenital anomaly in front of diabetic mother. Now, fetal hyperinsulinism is also going to impact the baby, not when the baby is in utero, but when the baby is delivered. So, in response to the maternal hyperglycemia, the fetal hyperinsulinemia was seen. But this hyperinsulinemia, soon after the birth, acts on the blood glucose level in the neonate and starts reducing it drastically. Now, this will result in jitteriness. When there is severe reduction in the blood glucose level, that can also cause seizures. Now remember, fetal hyperinsulinemia is also going to affect the fetal metabolism. It reduces the lung maturation rate, decreases the parathormone secretion, and it also will cause relative hypoxemic state, thereby resulting in polycythemia, increased red blood cell turnover resulting in hyperbilirubinemia, decreased lung maturation resulting in respiratory distress syndrome, and decreased parathormone maturation resulting in hypocalcemia and hypomagnesemia. And of course, at any point of time, if the maternal diabetes is associated with renovascular disease, or if there is a uteroplacental insufficiency, about 25% of the fetus may actually be small for gestational age as well. So in general, it means that the infant of diabetic mother is not always large for gestational age. About 25% of the cases will have small for gestational age because of the uteroplacental insufficiency because of maternal diabetes. So this is in brief regarding the pathophysiology. Now briefly to look at the spectrum of diabetic infant of a diabetic mother, the one of the thing, if we start from the chronology, you can see that most of the stillbirths or deaths in the fetal life occur in the third trimester in patients in infants with diabetic mother. There will be macrosomia, which is defined as a birth weight of more than 4,000 grams. Neonatal respiratory distress in the form of respiratory distress syndrome is also a well-known entity. Metabolic disorders or discrepancies in the form of hypoglycemia can be seen in 25 to 50% of the patient. Insulin is in excess in infants. So, because insulin is in excess, ketogenesis is not going to be a problem in neonates with infant of diabetic mother. So, there will be hypoglycemia, which is non-ketotic. There will be hypocalcemia and hypomagnesemia because of the decreased parathyroid maturation, and you can have coexisting polycythemia, hyperbilirubinemia, cardiomegaly in up to 30% of cases, and heart failure in up to 5 to 10% of the cases. Now, if you look into the infant of diabetic mother, this is how an infant of diabetic mother typically looks like. Large for gestational age, chubby face, hairy pinna, small head circumference, and the lower half of the body, especially in the region of the sacrum, will be less well developed, resulting from caudal regression syndrome. So these are in brief regarding the spectrum of infant of a diabetic mother. The LS ratio is a very important ratio which tells us about the lung maturity. And now it has been assumed that when LS ratio, that is lecithin sphingomyelin ratio, is assessed, and if the ratio is more than 2, the risk of respiratory distress is very low in general population. But there is an exception to this rule. So infants of diabetic mother, infants with erythroblastosis fetalis, and infants who have suffered intrapartum asphyxia, these are the three situations where their baby can still have a LS ratio of more than 2, but still they may be predisposed to respiratory distress syndrome. That means the general statement that low LS ratio is associated with very high risk of RDS is applicable for all, but the exceptions are these three: infants of diabetic mother, infants with erythroblastosis fetalis, and infants who have intrapartum asphyxia. Here, these patients have a very high LS ratio, that is LS ratio of more than 2, and hence LS ratio in these three subsets cannot be used as a surrogate for prediction of pulmonary maturity. So this is one thing you have to remember. Now next is an MCQ which is based on the organs which are going to have enlargement as an effect of anabolic action of insulin. So infant of diabetes is associated with enlargement of all organs except, the options are liver, kidney, adrenals, and heart. So what do you think the answer is? So here the answer seems to be Kidneys. The answer seems to be kidneys. The answer seems to be kidneys. So almost all organs in an infant of diabetic mother can undergo hypertrophy and appear enlarged. Exception for this general statement is the kidneys and brain. Kidneys and brain do not enlarge. Now, if you have to look at the infant of diabetic mother from anomaly point of view, the infant of diabetic mother is associated with a threefold increase in congenital anomalies, right from cardiac malformations, neural malformations, renal malformations, and GI malformations. All of them can appear. The most common cardiac manifestations would be asymmetrical septal hypertrophy of interventricular septum. If that is not given in the option, then you will have to look for ventricular septal defect. Now, in neural abnormalities, all sorts of neural tube defects and holoprosencephaly and other neural migration defects can also be seen. But the key feature of neural abnormality in an infant of diabetic mother is caudal regression syndrome. The lower half is underdeveloped. Lower half of the body is underdeveloped. And in fact, this caudal regression syndrome is unique to infants of diabetic mother, and hence this caudal regression syndrome is found to be a specific marker of infant of diabetic mother. Renal abnormalities can be in the form of hydronephrosis, renal agenesis and dysplasia, as well as double ureter. GI malformations in the form of duodenal as well as anorectal atresia, as well as situs abnormalities can be seen. There's also one more peculiar syndrome which is attached to infant of diabetic mother, that is lazy left colon syndrome or small left colon syndrome. So this is in brief regarding the spectrum of infant of diabetic mothers with respect to congenital anomalies. Penultimate slide asking about a question: which of the following malformation in a newborn is specific for maternal insulin dependent diabetes mother, mellitus? So here the answer, as I have already discussed in the previous slide, is called as caudal regression syndrome. Caudal regression syndrome. Now, what is this caudal regression syndrome? Now, caudal regression syndrome is a rare disorder which is highly specific for infant of diabetic mother. So specific that 200 to 4 times higher prevalence of caudal regression syndrome is seen in infant of diabetic mother than compared to that of other situations. Sacral agenesis and hypoplastic pelvis are the key features of identification here. And usually when this occurs, there will be coexisting malformations involving the sacral and the perisacral area, that is femoral hypoplasia, extrophy of the bladder and clubfoot as well. So I'll go with the last slide. I have a spotters of infant of diabetic mother. Now this is an infant of diabetic mother who is having macrosomia. You see the lower half. You see the lower half of the body. The lower half of the body is barely developed because of the caudal regression syndrome. There is macrosomia. The baby appears to be large. There is hairy pinna, small ear cartilage, hairy pinna, chubby face, and if you see there is some degree of microcephaly also. Now if you take the X-ray of the baby, you see that after this L2 vertebra, you are not able to see any spine. This indicates that there is some evidence of caudal regression syndrome. This is also called as sacral agenesis. Now this third image is best typifying the lower half of the torso, which is completely underdeveloped, thereby resulting in what is called as caudal regression syndrome. Now with this, we complete the topic of infant of diabetic mother. I hope we have covered almost all aspects of infant of diabetic mother. In addition to that, we have also touched upon briefly the management aspects of hypoglycemia, both symptomatic as well as asymptomatic. Thank you.
Best training, peaceful environment, PG medical entrance exam preparation were my expectations. I got them at Speed Medical Village in Kanchipuram. Today, I am a PG topper.
Speed Medical Village, a unique eco-friendly campus dedicated for PG preparation. Speed Medical Institute, a complete solution for medical education.